Hello, and thank you for having me today. My name is Katie Westman. I am a clinical nurse specialist currently working within Allina Health. I am a clinical director of programming for our continuing care service line, which is a integration of Courage County Rehab and Allina Home and Community Services. And home hospital is currently one of the areas of responsibility under my umbrella. I am here to talk to you about home hospital a little bit today. And my title here is deliberately provocative because I'm asking you to think about in the back of your mind as we go through these slides. Although this might feel new, I'm actually wondering if it is returning more to nursing's roots. Even 100 years ago, nursing would have done most of their cares where the patient resided, whether that was in an apartment building in a tenement in New York like Lillian Ward, or some of our colleagues delivering care by horseback in the Appalachian Mountains, or even go back to the 1800s and Florence Nightingale visiting or doing her nursing care on the battlefield. So while this might seem new and radical, I would make the argument that for nursing, even with new medicines and new technologies, in some ways, this is returning to care how we've always provided it. I would also like to give credit. Some of the content of the slides were also put together by Chris Ann Timpey, who is the medical director for the home hospital program at Health Partners. I have a few objectives for us today in our short amount of time. I just want to introduce you to this model, and you're going to hear me refer to it as a few different things: hospital at home, home hospital, acute care in the home, as we try and solidify this program and what it is and the regulatory requirements and other basics of the care model behind it. There's also been different vernacular, so you will hear me use those. I will try and use them where appropriate, but just know that there are multiple names for this care model. We'll also talk through some of the regulatory requirements. I'm hoping to enhance your learning through some case examples from the programs here in Minnesota, and then briefly talk about the future of the program. So what is this care model that we're talking about? Well, this is an alternative recovery option for patients. So hospital at home enables functional patients, meaning patients who can get up and go to the bathroom by themselves, get themselves something to drink, microwave a meal, that need acute care level care, can receive those interventions in their home rather than a brick and mortar setting. So why is this important? Why even go down this route? Well, this care model delivery has been shown to reduce cost to both the patient and the hospital system, reduce harm. Patients in their own familiar environments tend to have fewer infections, fewer caries, fewer issues with skin because they're up and moving more, which also means they have greater function. They retain more function than in a hospital setting. There's also drastically fewer incidences of delirium, as well as falls. Again, patients are in their own environment. They know how to navigate it, and just many, many fewer risks to them. All those things lead to improved outcomes for patients, which means at the end of the program, you have healthier patients who are in a better position to return back to their baseline. It enhances the patient experience. If you think about, hopefully, home is where you want to be too. After a long day of work or after a long trip, or even when you're ill, you want to be in your own space, in your own bed, on your own couch, in your own kitchen, with all those things that matter to you. And our patients aren't any different. And what I think is also very exciting is this improves the clinician experience. Patients are more autonomous, so they can do more things for themselves. And as a clinician, you experience things in a much different way. You can see what is potentially helping or potentially impeding their recovery because you're in their home. And that provides an invaluable insight into how to help your patients. While there's been a lot of buzz these last few years about these programs, you should know that here in the US, they've actually been around for quite some time. As back as the mid-90s, we were finding some of these improved outcomes. You can see here two studies, one for Johns Hopkins, one from Brigham and Williams, and you can see the reduction in serious incidences like delirium, a reduction in the use of sedatives, better physical activity. All of these things mean better outcomes for patients. And the US is actually a little behind. There's other places in the world that have been doing this for a lot longer and a lot larger scales than us, and they find the same outcomes. And of course, being CNSs and talking about hospital patients, we cannot go much farther without first talking about regulations. So there is a program under CMS, you might have heard it called as the CMS waiver program that designates home hospital. So while these programs have been around for a while, during the middle of the pandemic, so in 2020, CMS did put together a list of rules and regs for these programs. And it's called the waiver program because they waived the need or the requirement for 24/7 nursing care and instead require 2 in-person clinician visits for these patients in their home setting. It still requires an inpatient H&P. Patient must still meet inpatient criteria, and it mimics the inpatient setting very closely. Meds come from the inpatient pharmacy. All the documentation happens in the inpatient record. The providers are credentialed from the inpatient setting. And while you still need policies and procedures, you mimic as many inpatient as you can. And then where you need to modify, you borrow from our home health colleagues or other people that are used to working in the community. If you have any questions about how complicated that process is, talk to one of the other Alina CNSs. There are other homegrown models out there, including right here at Alina. So here at Alina, we do run the CMS waiver program. We also run another program we call Elevated Care at Home. And this allows us to do a few things. We can take all patient types, so observation, bedded outpatient from the community. We don't require that inpatient H&P. Care is very minimally different. So we have usually typically one clinician, sometimes two, but mostly one clinician visit. All the other standards of care are the same, including our quality and safety standards. Here's just a different visual that allows you to think about these a different way. So essentially for all of these tracks, whether you are coming from the ED, you are coming from the inpatient, you are coming from the community, all of these places get you home where you can continue that recovery there. For the CMS waiver program, again, remember you have to come from the ED or the inpatient side of things because of that inpatient H&P requirement. But from the community, you can stay home, never even see the ED. So you might be thinking to yourself, well, who are these patients? So here's generally speaking who we think of as eligible for this. Of course, they are acutely ill, so they need that daily monitoring that happens in the hospital. As I mentioned, they need to be functionally independent. That doesn't mean they're going to get up and walk across the room, but they do need to be able to get up and get out of a chair, for example. They have to be incapable of engaging in the program technology. And here I would just caution you that while we have encountered a few patients who have struggled or needed reteaching, I would say generally speaking, especially our older patients, they are much better at this than we expected them to be. So don't rule somebody out either because of age or they tell you they're nervous about the technology. We've kept it very, very simple. And then, of course, they need to have medical needs that can be met by the capability of the program. So IV antibiotics, medication titrations, management of oxygen, mobile tests and procedures. While we can do a lot, there are some things we can't do. Give blood, for example. So if we can meet their needs within the program, we'll take them. Here's another way to think about who is eligible. On this continuum of function, if you will, we know that if patients after have an acute event, there is going to be a subset of patients that is going to need to get care in a transitional care unit, a TCU, or a long-term care setting at discharge. They will not be able to go directly home. We also know that there will be this bucket of patients who can go home self-care or potentially need home health. They're going to be fine. They will recover on their own and have no needs at discharge. And then you have this area in the middle. So for home hospital patients, there's two really important things here. One is that at either end of this spectrum, we are assuming the patient has met discharge criteria. In other words, they have fully recovered and no longer need the acute setting. For home hospital, that is not true. We can take patients who still require that acute level of intervention. So they have not met traditional discharge criteria from a hospital. And this is the hardest one for clinicians to understand. If most people who have had hospital experience also think about this is a group who may have some functional needs, but we can provide physical therapy in the home. We can provide other supports for them, but they have to be mostly functional or a caregiver that can help them as well. And these also might be ones who we just want a little extra monitoring. We're not quite sure they're ready to go home self-care, but they need a little extra. In contrast, here's the folks who are not eligible. People that are pregnant, it's not because we can't, we just don't currently have an OB capability. People who have home safety issues, people less than 18 years of age, again, not that we can't, we just have not developed our pediatric competencies yet. People in skilled nursing facilities. Typically, these patients already have a care team, whether it be nurses or physicians they follow, and this more becomes a matter of complications of communicating with that team rather than these patients might still need this level of care, but that gets tricky. Obviously, people needing ICU level of care, intravenous narcotics, or people with an active substance use disorder. So the other key here is to know that this will never fully replace the hospital setting. There are always going to be people who need that inpatient level of care for a variety of reasons. But for patients that don't, this could be a good alternative. So let me help you visualize a little bit of what this might look like. Again, if you work in a hospital setting, very familiar what that looks like, and you're going to see some similarities here too. So when the patient discharges home, or if they're already home and enrolled in the program, the first person they'll meet will be a community paramedic. And that paramedic will come and do a home safety evaluation, make sure that they have the medications to get them started, and will also deliver a biometric kit. And this is also the key to being in home. Patients in this program will receive a blood pressure cuff, an O2 monitor, a thermometer, and sometimes a scale, depending on their condition, that are all Bluetooth enabled and cellular enabled. Patients also receive a tablet, and on that tablet is where they will do video visits. It's where all of their vital signs, because they take their own, will upload, and it's also how they communicate back and forth with the team. Now, every program does it just a little bit differently, but some programs have interactive capabilities. You can send a question to a patient. How are you feeling today? What's your weight today? Any concerns today, you can send instructional videos, education videos right through the tablet. So that kit all gets delivered and explained and set up that very first day. Then the first full day in the program, they will have a clinician in-home visit, either one or two, depending on which program they're in, either a video or an in-home provider visit. And then, of course, that patient is providing vital signs throughout the day. Then depending on patient condition, other things will get added. They might have someone come draw labs, they might have an ultrasound or a chest x-ray ordered, they might have physical therapy come visit, and then that care is ongoing day after day depending on patient needs. So they will continue to get daily in-home clinician visits, daily provider visits, and then that real-time modification to the plan. And this is what makes the program so special, is that ability to titrate medications, to change an antibiotic, to do those things real time. And then at discharge, they're signed off back to primary care or home health or other services as needed. This is a more in-depth grid of what happens within that program. So when you get the slides, if you want to read a little bit more about it, I encourage you to take a look at slide 12. It's important to take another pit stop here and talk a little bit about how this is different from home health, because you might hear that, well, wouldn't we just send the patient to home health, or the patient would go to home health anyway? And here's really the differences. We're going to start at the top with the acuity. So patients in a home hospital or a hospital at home program, they need those daily monitoring and titrations of medications. They need, even though home health can do IVs, it's usually a set plan versus being able to change things up. The duration of care is very different. So we are looking to resolve an acute issue in that hospital at home. So anywhere from 3 to 5, can be as long as 7 days, but typically it's much shorter than that. Home health, it's generally 30 plus days that they're with those within that program. The frequency of interactions with the care team is different. So in a hospital at home program, you are seen daily, sometimes multiple times a day, by someone from the care team. So that could be a nurse, it could be a community paramedic, it could be a provider. You will have that kind of that daily rotation, if you will, for patients. In a pure home health program, that is 1 to 3 times a week by, again, could be a variety from the skilled team, but it's not every day, and typically not more than one team member each day. The physician engagement or provider engagement also looks very different. So again, the hospital at home program, it's going to be daily medical management, which means within minutes or hours, the person in the home, whether it be a nurse or a community paramedic, is connecting back with that provider so we can do those real-time changes, real-time orders, Whereas in home health, that team is communicating back with primary care. And again, you can imagine that will sometimes can take a little bit longer. So you're typically communicating about needs that can be resolved within 24, 48 hours versus within minutes to hours. And then the last piece, again, is just the being able to do those real-time changes in the plan of care like you would in a hospital. And in home health, you're going to rely more heavily on primary care protocols, often sending patients to the emergency room for any kind of escalation, whereas those can be managed within the home hospital. So who benefits from this program? I want to spend a little bit of time here talking about our patients because as we all know, in a hospital environment, because it is heavily regulated and because of the variety of patients we need to care for, patients lose a lot of their autonomy. They are on our schedule, they're eating our food, they're in our beds, wearing our hospital gowns, and even to the best of our abilities, there isn't a lot we are able to do about that. In the home, it's the opposite. They are in their own surroundings. They're eating their own food. They're watching their own shows on whatever streaming service they so choose. They have their pets around them. I had one woman tell me it was such a relief to her to be able to water her plants, go get her own mail, those things that we take for granted that you lose when you're in a brick and mortar setting. There's comfort in being in your own home, both, again, just that level of stress that reduces when you're in environments. But for folks who have a hard time being outside of that, think of our folks with any kind of memory or acquired brain injury. So TBIs, any kind of cognitive impairment, memory impairment, they do better in their own surroundings. Patients who have English as a second language, who again are around things that they understand and they know, they are going to recover in a much different way. And then familiarity. This is, again, think about this in terms of patients who either have high mental health needs in terms of anxiety or even as dramatic as agoraphobia, right? Being in their own environment can reduce that stress level internally and externally, meaning they're going to recover faster and potentially reduce complications that come from when you are struggling to communicate or someone who really gets agitated or anxious outside of their home environment. So there are true benefits to folks. Not everyone is well served in a brick and mortar setting. So I'm going to quickly run through some case examples for you. Here we had a patient we took care of within the Aligner program from the emergency room. She was an 81-year-old female who had come with the signs and symptoms of pneumonia. And patient and family were adamant about not wanting to be admitted for a wide variety of reasons. And so when they were presented with this option, the patient was absolutely ecstatic. She ended up going home with a new oxygen order, antibiotics, and just the ongoing monitoring for the next 3 to 4 days. She received all of these cares at the home. The daughter was able to come and stay with her and provide 24/7 support comfortably in the guest bedroom, and then being able to just be with her mom. So this patient spent 0 nights in the hospital, went straight from the ER to home. She was discharged from the program 4 days later, recovered, functional, and so grateful to be able to be in her own home. This is an example of a patient we took from our community setting. So Alina has an in-home primary care program for complex seniors. And as you can read through this patient's history, very complex, long-standing both cardiac and pulmonary issues. And so at a in-home visit, the MD noticed both worsening edema and hypoxia. So she was admitted directly into the home hospital program, never even saw the ED or the hospital. She was given IV diuretics, daily lab checks, and adjusting those meds to manage both the extra fluid and monitor what else was happening. We helped coordinate an appointment with cardiology while she was in the program, and she did discharge with a line of PT and OT in the home after her episode was ended. This patient ended up staying with us for 7 days while we managed her, and again, incredibly grateful to not have to leave her home. And one final example about a hospital admission. This was a 77-year-old male who had had a stroke several years ago with significant functional improvements. He was admitted for cellulitis, and after being stabilized and a long discussion with the wife and daughter, they had set up his home previous to this to really be able to care for him, and they were doing a marvelous job with it. So after starting antibiotics and watching him for about 24 hours, he was discharged home with his wife and his daughter. After several days, he was switched to oral antibiotics, and the home team, along with the wife and daughter support, were able to manage all of it. His home medications, including the tube feeding, the IV antibiotics. The wife did complete the vital sign monitoring and the video visits with the provider, and again, was so grateful to be able to return the patient to his home environment, their home routines after a minimal disruption. So a brief slide to just show you how prevalent this now is since COVID. All the blue states are states that have one or more programs up and running. So it is becoming more widespread. Within the CMS program, there is a requirement that you need to be within 30 miles of a hospital or emergency room. So you can see some of our states with more rural populations are going to struggle with that requirement. Currently, reimbursement is a little interesting. So Medicare, this is covered for Medicare beneficiaries who meet that inpatient criteria, the same as a traditional hospital stay. After that, it varies pretty wildly among payers, among location. And then you can see Minnesota Medicaid, this is not yet a reimbursed service. Although for this population, it could be huge. So here's the work ahead of us, getting more understanding about this model of care. And again, talking through who's eligible, who's not, who it works for, who it doesn't. We need more recognition from legislators and community leaders, and more understanding of what's going to happen after December 31st. So this CMS waiver is set to expire after that date. All signs point to it being extended, but we need to really nail down the components so we can do this more consistently across. And the other things we need: standard payment models, standard rules and regulations, and then the understanding of the impact to the caregiver, and potentially the opportunity to have paid support for caregivers in the home. I'll leave you with a few questions, thinking about what excites or concerns you about this model. And from a policy payment perspective, if that is an area of interest, what questions would you have if you were either on the policy side or the payment side that we would need to answer for you before you could feel comfortable? And just in general, what other questions would you have for our presenters before you felt either comfortable with the program or talking with somebody else about it? Because I am sure there are questions out there, wanted to leave you with both Chrisanne and my contact information. Please do not hesitate to reach out with questions or other things you may want to know. The more questions we get, the more it helps Chrisanne and I learn potentially how we need to advocate and what we need to present as well. Again, thank you all. I hope you have a lovely rest of your conference, and I look forward to talking with you soon.